My name is Karl Hegyi. I'd like to welcome you all. Today we're going to be talking about a system of patient treatment and evaluation called the physiologically guided treatment system. The methods and concepts of this system are taught in a program called the Full Mouth Mastery Program here at the Center at Dental Ceramics. Now, as the title suggests, this is about knowing and not guessing when we're doing treatment, especially if we're doing complex restorative treatment. Now, today's introductory presentation will be divided into three primary parts. First, and taking most of our time, we want to give an overall overview of the system. Secondly, we want to talk about the three primary tools of the system. And finally, we'd like to conclude just by going over a little bit the logistics of the actual program itself. So with that being said, before we get going, I actually need to make a disclosure. We're going to talk quite a bit about this thing called the data appliance, and it is a trademark I own. And the reason I own it, though, please understand, is strictly to control the fabrication and utilization standards. I make a profit not at all from this fabrication whatsoever. So with that being said, where did this journey begin? Well, it really began back in the early 1990s when I was wanting to do more dental implants. And understanding that occlusion was an important element in the implant success, I wanted to study under Peter Dawson. You know, he certainly was the most famous and probably the most respected occlusion individual back at that time. And I came to learn Pete Dawson, became very close friends with him. And I studied everything he had. I took every course he had. I read all of his writings. And again, he became not only a very good friend, but very much of a father figure to me. And I was very much honored by him back in 2004 when he asked me to become a visiting faculty member at the Dawson Academy. But in any event, I went on and learned everything I could from Peter Dawson, and then went on to learn from and study under Frank Spear and John Coyce, and learned a lot from them. And what was interesting is that when I utilized their concepts, their methods, their systems, and I was doing treatment, especially complex treatment, I found oftentimes there were gaps. I was at points of making key critical decisions, and I wasn't sure what to do. And that caused stress for me, it caused inefficiency, and it was at that time that I really vowed I wanted to develop a system that would really kind of fill in the gaps. And so understand this system, that's where this system came from. Now, this system is not intended to just disband or throw away what I learned from these three great individuals, but it was really intended to build upon them. So as you'll go through today, you'll see and probably recognize a lot from Pete and John and Frank. But I guarantee you and I assure you, you're also going to see a lot of things that you haven't seen before that are really the result of what we've added on and built on. So that being said, let's talk about what this system actually is. What is the definition? Well, as the title suggests, it's really about making functional and aesthetic change. But specifically, it's about making those changes as a result of either changing tooth position, which of course is orthodontics, or of changing tooth shape. Now, changing tooth shape, we think typically of restorative dentistry, which it certainly can be. But we also understand that changing tooth form, can also be a result of reductive reshaping. We'll give examples of both of those. But the point is, this is the kind of dentistry that, to me, really changes patients' lives. And to me, it's fun. To be honest with you, it's really only fun if it's done in a safe and predictable manner. Also, if the system ensures control and flexibility and really efficiency and profitability. So how does our system do this? How does it ensure that? Well, it does so starting from the very beginning. And what it begins with is an understanding that all treatment, from the most simple to the most complex, can really be broken down into three primary parts. We have first of all, we have evaluation. Secondly, we have planning. And then finally, we have treatment. And what our system does is we've developed methods and concepts that address each of these elements in our own way. And these concepts and methods are largely dependent upon the three tools. And these are the three primary tools of our system. And they are the data appliance, which is really kind of the heart and soul of the system, as it's involved with all three elements. It's involved with evaluation, planning, and treatment. Secondly, we have verified and validated mounted cast. Well, this is all about planning, but more specifically, it's about very predictable planning. And when we talk about predictability, that's something that we see so commonly thrown around in dentistry or used so commonly. We're going to be very specific in defining exactly what do we mean by predictable planning. That's a very important element of what we're trying to achieve. And then finally, we have this stable biomechanical foundation. And as we'll see, that is all about treatment. Now, we'll spend most of the rest of the time of this presentation talking about these tools and how these tools are used to really address all three of these elements of evaluation, planning, and treatment. So what is the goal of this? Well, as the title sort of suggested, it's to take us from guessing to knowing. But what do we mean by this? Well, I think it's probably best illustrated to give an example. And in this example of a treatment protocol, and this is unfortunately a very common protocol, is where the dentist preps a full mouth of tooth preparations for crowns or veneers or combinations very typically. Then they send the impression and a bite to the laboratory, and they send the following instructions to the laboratory. And the instructions say something like this: make teeth, shade OM1, do an extra good job, and rush, I need it tomorrow. And while this may be a little humorous, we almost chuckle at it, the reality is when I've given this presentation to lab technicians, they kind of shake their heads and say, this is what we see all the time. So this really begs the question then is, when you're providing treatment, especially treatment involving change, which is what we're really all about here today, do you want to guess or do you want to know? Or also, very importantly, equally importantly, do you want your lab technician to guess or do you want them to know? However, let's address these questions further by asking this. So when we're providing this treatment involving change, when is it appropriate to guess and when should we know? Because the reality is that in our process of evaluating and planning and treating patients, there are times that we'll make some forms of guessing. But in our system, we very clearly define and understand that guessing and knowing are not absolutes. Again, in our system, we have 4 very clearly defined levels of guessing and knowing. And they are, first of all, we start with a blind guess. Secondly, we have an educated guess. Third, we have tentatively confirmed. And then finally, we have definitively confirmed. So if we look at those and what do those mean? Well, first of all, a blind guess means I really don't have a clue. I don't have enough information to make any kind of intelligent decision. Now, an educated guess says I have enough information to be maybe 50% confident. Then tentatively confirmed, I'm maybe 97% confident, and then definitively confirmed, I'm about as close as you can be to being 100% confident. Now, one important point to note here is the vertical striations here of these 3 levels, or these 4 levels of knowing. And you see there's a significant difference between a blind guess and an educated guess, and then between an educated guess and tentatively confirmed, where there's only a very little amount between tentatively confirmed and definitively confirmed. And what that means here basically is that, first of all, that means that there's the probability of us being right or wrong, but also the amount or the magnitude of the error that we might experience. For example, if we take one of our elements that we're going to talk about, aesthetic design. Well, if we are tentatively confirmed, that's saying that there's about a 97% chance that we are spot on. But even if we are off, even if we're wrong, the chances are that the modifications we need to make are very, very minute. Whereas an educated guess, well, I'm about 50% confident, but also there's about a 50% chance I might be wrong, and I might be wrong by a whole lot. So it's not just the probability of being right, but the magnitude of any error that might be present. And I think the importance of that will come back when we get into our cases themselves and what that means. So with that being said, I think there are a couple more questions, or a few more questions we need to ask. And first of all, what are these key elements that we need to know? What are they? Well, and for example, we have the vertical dimension of occlusion, we have the aesthetic design, and then we have condylar position and condition, and then we have the envelope of function, and not to be forgotten, we have the psychosocial status of the patient, a very, very important element. Now, secondly, the second question then is, in a given patient or a given case, which of these do we need to know? We certainly don't need to know all these elements for every case, especially a very simple case. Then third, very important, we're going to want to really delve into this when we get into our patients. When should I be at each level of knowing? In other words, for each of the elements that I need to know in a given case, when should I be at a level of being an educated guess? When should I be tentatively confirmed? That is going to play out and be very important. And then finally, 4 and 5 are the concepts and methods I need to learn, and then also finally the clinical skills. Understanding that concepts and methods are one thing. We might understand something, but clinical skills, as we all know as dentists, is a very different matter. And again, if you've studied under either Dawson or Coyce or Spear, some of these methods and some of these concepts and skills you will probably be familiar to you, but some of them I'm sure are going to be quite new. So with that, I guess we should move on and say, so what type of patients is this system really developed or designed for? And what I have found is that these are really great. These terms are really great communication tools, and they are problem profiles and treatment paths. And problem profiles, we're going to talk quite a bit about here today, is very important, very helpful among dentists, whereas treatment paths are nice communication skills with patients. And what's really nice, for example, rather than using the term treatment plan, treatment path suggests different divergent directions, okay, where plans don't really suggest a direction, where our paths are, again, divergent directions. But anyways, let's begin by talking about problem profiles. And to begin with, we need to understand that problem profiles are the result of evaluation, and they are a very objective element. And they are the result of considering the status of the patient functionally or biomechanically, structurally, and aesthetically. Now, we also certainly consider the patient's microbial status, but there's nothing about our system that really uniquely addresses those issues. So we're really focusing on the biomechanical functional elements, the structure, and the aesthetic. Those are the really defining elements. Now, if we talk about treatment paths then, unlike problem profiles, treatment paths are not purely objective. They are certainly influenced by the problem profile, but especially when we get into dentistry that involves change and an elective type of dentistry, a given patient with a given profile may be choosing very different paths. And that can be influenced by things such as the patient's values, their financial situation, and just their whole psychological makeup, their whole psychosocial status. And so for a given problem profile, and we will illustrate this actually with our first patient, a given patient with a given profile may have multiple paths that they may choose. So again, good communication tools. So now what I'd like to do then is let's talk about the problem profiles themselves. And this is very, very important. And what specifically are the problem profiles that this system was designed for? And there are 3 of them. And the first one is problem profile 1 is number 1 is occlusal disease or TMD or oral facial pain or basically head and neck pain type patients that we see that really have no restorative needs or no restorative issues. Secondly, patients that have occlusal disease or any kind of biomechanical or pain disorders, but they also have restorative issues to go along with that. And then finally, number 3 we see are patients that really don't have any problems. They don't have any biomechanical or occlusal disease issues. However, they want restorative treatment. And typically, this is going to be patients that want to have more aesthetically driven type of treatment. And what we find in these patients that often, and I get these patients referred to me all the time where they go in and they had no problems. They just wanted to have a nicer smile. And all of a sudden, as a result of that treatment, now they're having these aches and pains. Their jaws are hurting and their restorations are breaking and cracking. So the bottom line is it's very clear to understand that from here going on, the patients we're talking about are those that fit one of these 3 profiles. This is not to say that every patient that requires or can benefit from extensive restorative treatment it fits into these 3 problem profiles, but my experience is that the large majority of them do. So with that being said, let's look at a problem profile number 1 type of patient. And let's look at Kathy here. And I guess the first thing we would ask is, well, wait, where's the problem here? I mean, when we look at this patient aesthetically, I mean, that looks great. I mean, she looks beautiful. And she had orthodontic treatment, and I'd be very confident to say that the orthodontist that did this was probably very proud of that outcome. They probably, took pictures of this and said, look at my work, look how great it is. And if we look even at the unmounted diagnostic study casts, if we just look at them in maximum intercuspation, we look at those and we see, they are class 1, they meet all 6 of Larry Andrews' keys to a normal occlusion. But I want to say something about occlusion, because and today does not permit us the time to go into occlusion nearly as much as I would like to. But when we look at most classifications, most considerations of occlusal success, everything is based on these static relationships. If we look at Larry Andrews' 6 requirements for successful orthodontic treatment or angles classification 1, 2, and 3. Those are all static relationships. And what I have found is that if we are concerned about the interocclusal relationships and how they impact upon any component of the masticatory system, these static relationships are not very important. We need to understand, and we'll talk a little bit about it, how we need to consider it as an interactive phenomenon. So occlusion, functional occlusion, is an interactive phenomenon involving the interaction of upper and lower teeth. And we'll talk more about that when we get into our second case here. So anyways, this is a great case. So where's the problem here? Well, when she was in for her hygiene appointment, Kathy, our hygienist asked, Kathy, do you have any kind of head and neck pain? Which I think every hygienist should ask every patient. And she said, as a matter of fact, I do. And so we went into a little further. We had her fill out what we call our facial problem questionnaire. And she went through and we discovered that, geez, she was having, 4 or 5 days a week. She was having 7 out of 10 level pain. I don't want to live like that. I mean, my gosh. So this is a patient that definitely, you wouldn't think of this beautiful looking case having problems, but she certainly did. So what we want to look at here, we put Kathy in a data appliance, and these are her verified and validated mounted casts. Now, for right now, we're going to go more into what that means in our next case. But for right now, what I would like you to understand is that what you're looking at on the screen here now represents the interocclusal relationship that is realized or resulting from her most physiologic masticatory muscle activity and with the condyles in their most orthopedically stable position. That's what we're seeing. That's what we're seeing represented on those photographs, on those verified and validated mounted casts. And what is interesting to realize here is that when Kathy was in that position, when she was in there with her dad appliance, she had 0 headaches. She didn't have a little improvement. She had no more headaches. And so one of the neat things I learned was the fact that before we even began to treat her, I knew that we could eliminate Kathy's headaches. So we went on and we talked to Kathy about 3 possible treatment paths. And one option would be for her to go back in and redo her orthodontics or to refine her orthodontic treatment. Another option would have been for her to make, or for us to make, an occlusal appliance for Kathy. Now, one thing, if we were to do that, a very important point here, is that if that were to be a choice, which we oftentimes do, we make a lot of occlusal appliances, it's important to be made at this interocclusal relationship. In other words, the relationship that we've captured here in these models, on these mounted casts, not her relationships in maximum intercuspation. But our third option was to do definitive occlusal adjustment, and that's what Kathy chose. So what we have here is we have our diagnostic occlusal adjustment that we proposed to Kathy. Again, this being done on verified and validated mounted casts, which means that she was right where we wanted to be, where everything was in its most ideal relationship. And what I'd like you to look at here, and what I'd like you to note is that we actually included in this case, this is not an equilibration. We actually incorporated additive reshaping into Kathy's case. And this is the process we refer to as redatabration. And redatabration basically is not just saying that, wow, we have a case here where we do an equilibration. And even with equilibration, sometimes at the very end, you might find you need to add an occlusal stopper here. No, this is not what this is about. Redatabration is it's not only a method and a skill, but it's very much of a philosophy. And what it really understands and appreciates is the fact that we want to use, with the concurrent utilization of reductive and additive reshaping, one of the really neat things we have is we have complete control over the vertical dimension of occlusion and the things that vertical dimension of occlusion impacts upon. And we're going to talk a little bit more in our next case about what those things are, but again, I wish I could go more into detail. But the point is, this is not just a matter of adjusted teeth reductively, and if you have to, add on. It's a matter of considering and planning where should we strategically do our reductive and additive reshaping. So with that, I want to move on here, and let's look at where we see Kathy's actual treatment. And what I'd like you to do to begin with here is look on the left side. This is what we projected for Kathy from our planning on our verified and validated mounted cast. And what we see on the right side of the screen is Kathy's actual treatment, her actual outcome. And if you look at those, they are virtually identical. This is the true test of predictable planning. So the true test of predictable planning is what you project, when you project, whether it's from a functional standpoint, from an aesthetic standpoint, or restorative standpoint, when what you project is what you actually realize in the actual outcome. But with this being said, I'd like to go in a little bit about this idea of redatabration and reductive and additive reshaping, and how did that impact upon Kathy. So I'm going to look at 3 elements and talk about how would they have been different if we had done a standard equilibration, where we would have reduced really until everything came together. First of all, upon the resultant vertical dimension of occlusion. Well, as I was taught to do an equilibration, I was taught to do reductive reshaping until the anterior teeth came into the same relationship they had vertically and horizontally in maximum intercuspation. So basically, in that case, we would have maintained her vertical dimension in the anterior segment. Now, on the other hand, with what we did, we actually increased the vertical dimension in the anterior segment, because as a result, or after our reductive reshaping was completed, we still had some space vertically and anterior posteriorly. So we actually increased the vertical dimension of occlusion, which has some very nice benefits, which we'll talk about in our next case. But secondly, how about the invasiveness of treatment? Well, if I were to weigh the enamel dust that we would have generated from doing completely reductive reshaping compared to what we actually did as a result of incorporating the additive reshaping, what we did probably resulted in about 1/4 as much reductive reshaping. So it typically dramatically reduces the invasiveness of the treatment. And then finally, what would have been the impact upon the time actually necessary to provide the treatment? Well, if you think about it, what we did in Kathy's case, we reduced with minimal reduction until all the posterior teeth were coming into contact with equal intensity simultaneous contacts. And at that time, in this case, number 6 just happened to be coming in at that same time. So think from that point on, I have a choice. I can either continue to meticulously adjust all those posterior teeth and the anterior teeth until everything comes together, or I can at this point in time stop, put a little dollop of composite on the linguals of, in this case, numbers 7 through 11, had the patient close down, squeeze, cure them, trim them up a little bit, polish them, and it's dramatically quicker. It takes so much less time. And I've done hundreds of thousands of these additive reshapings with composite, and I could probably count, and this is going over, what, 20, 30 years, I could probably count on the single hand how many times I've had to replace them. They don't fail. But in any event, that's an important point to know, an important element of this whole idea of redatabration. Now next here, we can look at if we look at the lower arch, and we can see again, they're virtually identical. Now, a key understanding here is, as a result of doing our redatabration with our data appliance, we have now created that thing we talked about earlier, being a stable biomechanical foundation. Now in Kathy's case, that involved a combination of reductive and additive reshaping, and that was the end of her treatment. Now in other cases of redatabration, we're going to show you some in our next case, that process may be a totally additive process where it's completely additive. There's no reduction at all. Or in other cases, which I'll show you right now, it may be a purely reductive process. So in this case, in this situation, what we found was when the posterior teeth came together, at the very same time, all the anterior teeth came together at the same time. So everything kind of happened at the same time. And once again here, I would like to ask you two very important questions about this. So if you are doing definitive occlusal therapy, as I'm demonstrating here, my first question to you is, do your projected outcomes match your actual outcomes just precisely? And secondly, does it typically take you more than 1 or 2 visits to get the occlusion to stabilize? And I'm going to answer those from my personal experience, from my previous methods. Number one, I always did, and I would always say, do not even consider doing an occlusal adjustment without doing it diagnostically first. But when I would look at my actual cast, the cast from what I projected versus what the actual outcome was, almost always there was some difference. Sometimes that difference was just a little bit. Sometimes it was almost scary, dramatically different. So, but here you can see that almost without exception, they are virtually identically the same. Again, the idea of predictable planning. And secondly, again, is about how many times does it take to get this occlusion to stabilize? I never in personal experience of having done hundreds and hundreds of equilibrations, never had an occlusion stabilize in less than at least 3 visits. And typically it was 4 to 5 visits. You would go in, I'd go in, we adjust the occlusion with, in my case, typically with manipulation. The patient would come, they'd say, oh, feels good. Come back in a week. Oh, my bite's off again. It's hitting over here. If I adjust it again, feels good. Come back in a week, it's off again. Typically 4 to 5 visits to get that to stabilize. With the methods we're using in our system, in the large majority of cases, it's kind of a one and done. In other words, we do one occlusal adjustment, one session, and it usually takes about 60 minutes. We'll have the patient back for a follow-up, and maybe we'll have a little tweak here or there. Not typically, though. Now, in patients who have joint issues, which we're not going to get into today, that may be more adjustment. Typically, that's a 1 or 2 appointment visit. Okay, so the next question is for those of you who aren't doing this type of treatment. And my question to you is, why aren't you doing this type of treatment? And I know the reality is that you weren't trained to do this. And I understand this. And it's scary. And you can't visualize even making a profit. And you're worried about getting into trouble. But I need to make a statement, a very clear statement here, is that if you are going, and this is my strong belief, is that if you are going to be doing the type of restorative dentistry we're talking about here in our next case here, and if you're doing it on problem profile patients that we're talking about with our system, that if you don't have the concepts and the clinical skills necessary to do what I'm showing you right here, you really should not be doing that complex restorative treatment. Because number one, as you will see, we're going to be doing this. We're going to be creating a stable biomechanical foundation in our patient prior to doing their restorative treatment, prior to doing the tooth preparation appointment. And secondly, when you get your cases back from your lab, do you think those cases come back so precisely that there's no adjustment necessary? So it's my strong opinion when treating patients of the problem profiles we're talking about in our system here, that you need to learn and understand both the concepts as the skills necessary to do this. So with that being said, let's move on and talk about a problem profile number 2 type of patient. And this is Larry. And Larry is a dentist, and he's become actually a very, very good friend of mine. And Larry, as you can see here, aesthetically has some challenging issues here. Secondly, I think we'd agree too that structurally he has some chipped teeth, some broken teeth, some restorations that look, well, he has some structural issues. So let's look at the outcome on Larry here. And here we see an occlusal view, and then here we see a view of the anterior teeth, and here we see an approximate 10-year follow-up on there. I think things have held up pretty good. You can kind of judge for yourself here. But let's look at Larry here again from the standpoint of where he looks from before to end. I think we'd all agree this is a life-changing treatment. But I want to go into this case a little deeper. And it's a great case. It's a great case to illustrate many of the concepts and methods of our system here. In fact, actually, this treatment, this case, was featured in a 25-page article in the Journal of Cosmetic Dentistry a few years ago. And at that time, interestingly, the article was named A Systematic Approach to Functional Aesthetic Treatment. And the reason it was called that was because my system at that point in time was still in development. Many of the features were there, but I didn't even have a name for it. Today, it would certainly be called the Physiologically Guided Treatment System approach to aesthetic and functional treatment. But what I would like to do with this case is to demonstrate how this system and the tools are really used to address each of those elements of evaluation, planning, and treatment. And then what I'd also like to do is to show how this system is used to advance each of those key elements from a blind guess to being definitively confirmed. And then finally, very important, is we want to understand or hopefully make clear the advantages of knowing and confirming these elements prior to doing our restorative treatment itself. So with that being said, let's start off here by saying, what brought Larry into my office in the first place? Well, it was pain and dysfunction. It wasn't the aesthetics or his broken down teeth. He couldn't eat. He was in such pain, he could not eat. And so look at his goals. He primarily wanted to be able to function without pain. So Larry really presented as a TMD case. And that's really where he began. Now, we all know where this case is going to go because I've already shown you. But let's take a look at Larry and maximum intercuspation. And think about, what I'd like you to think about here is in the process we're going through, understanding that it is going to become a restorative treatment case, where would you have begun your restorative treatment? When would you said, okay, now it's time to start preparing teeth? And compare that to what we're going to actually show you here. And again, remembering this is truly a TMD case. So although we begin the process, of course, with evaluation, I'd like to first talk about the planning phase. All right, now, with the type of dentistry we're talking about doing here, with our problem profiles and with the changes that we're looking to accomplish, this really should be done on mounted diagnostic study casts. And as we look at those casts, I think they look really good. They're clean, they're neat, it looks pretty nice. But I will tell you that these mounted casts can be your best friend or your worst enemy. And what do I mean by that? How can they be your worst enemy? Well, we're going to plan on these mounted casts. What if it's wrong? What if our mounted casts are wrong? And by that I mean, what if that relationship doesn't truly represent that patient's interocclusal relationships with their most physiologic muscle and joint activity? Okay, like we showed in Kathy. Okay, no, we showed how if it is, but if it didn't represent that, what we would find, and what I found was that my planning did not match what actually happened. And at the very best, this was a cause of stress and inefficiency and loss of profitability for me. And at worst, it was disastrous. And again, as Peter Dawson would say, ask me how I know this, because I had that happen. Those are the types of things that led me on to develop this system. On the other hand, if the mounting is correct, if it truly does represent that most physiologic relationship, which we demonstrated in Kathy, life is good. And so let's see how that goes. So let's see how we do that. And the way we do that is, again, by doing this thing we called earlier, verified and validated mounted study casts. And what's important to understand is that this process, this verification and validation, is the result of evaluation, okay? And so how do we do that? Well, there are a number of different evaluations that we don't have time to talk about today, but by far, the most information and almost everything we need to do to accomplish this verification and validation is in response to the patient, to the data appliance. And so the data appliance in its first role then is done in the role of evaluation. Now, and the active part of this appliance is the stop, which is circled in the little green arrows there. Now, for those of you who have studied under John Kois, you may say this looks kind of similar to a Kois deprogrammer. And actually, to be honest with you, it really did. I started off with a Kois deprogrammer, and it made significant differences in what I was able to do. But what I found was, and I kept making changes to refine it even more and to make it more predictable and to give me more information. This is what it ended up being. This is what it finally evolved into several years ago. And I still called it a Kois deprogrammer. And I was giving a lecture to a number of Kois students at that time, and one of the students came up afterwards and said, Karl, that's not a Kois deprogrammer anymore. And he wasn't being rude. He was just saying, Karl, you should take credit for it and call it something on your own. Okay, he was being complimentary. So it came up with the name Diagnosis and Treatment Assisting Appliance, which is what it really does. So anyways, it's pretty cool. So what we did, put it in the patient's mouth, and what you'll note here is that I added on quite a bit to that stop, to that bump in the front. And the question becomes why? Why did they develop it? Why am I taking a bite registration here at such an increased or open vertical dimension? Well, let's look at the actual bite registration itself. And what we'll see here is that in reality, even at this vertical dimension in the anterior segment with that stop, we're almost in contact on numbers 15 and 18. And here then, if we look at the actual verified and validated mounted cast, and again, I don't have time to go into all the things that are involved with or required to come to this point of being verified and validated. But one of them is you have to have reproducible bite registrations, but there's more to it than that. But again, understand too that almost all these requirements are realized as a result of the data appliance. But what we need to understand now is a result of this verification and validation process, we've done a few things. Number one, we have definitively confirmed condylar position. And time doesn't allow me to go into all the things that are required to do this, but importantly to understand that the data appliance is responsible for this registration and also this recording more than anything else. And again, so what have we accomplished as a result of this? Well, first of all, we have definitively confirmed condylar position. Again, that condylar position that represents the most physiologic muscle activity and the healthiest condylar position in the fossa. Secondly, it tentatively confirms that thing we're not going to talk much about condylar condition. What is the actual orthopedic stability of that joint? It tentatively confirms that. And we're not going to go a whole lot more into that element as much as I would like to. We don't have time. But also, what it's done, it's confirmed or established a cause and effect relationship between Larry's interocclusal relationships and the pain he was having. Because guess what? In this position, Larry had no more pain. And so guess what else happened? This is no longer a TMD case. Now Larry's asking me, hey, Karl, I feel good now. Can we do something about my ugly teeth? He didn't say that word, but can we do something to make my teeth look better, to fix my teeth now? And I cannot tell you how often this happens. The patients that come into me in pain, you get them out of pain, a couple things happen. Number one, they trust you. They believe you. And number two, their priorities change. Now they want to have a nice smile. Now they want to fix their broken down teeth. So in any event, let's move on here. And again, we see here the difference here between maximum intercuspation on top there and the verified and validated mounted cast here. So it is at this point in time that we can begin the process of planning here. And one thing I would like you to think of, first of all, is with your current bite records, bite taking methods, I guess I would say, would you have got this same bite relationship that we have here? I wouldn't have. I know I would not have. And I want you to think about if you had planned this case out at a different relationship, whether it was maximum intercuspation or whether it was something in between that and what we actually are showing you here on the lower, what would have been the outcome of that case? And I'd really like you to think about that. So anyways, with that, let's move on and talk about the planning now a little bit. And so here we see Larry's right lateral view, and here we see Larry's left lateral view. So when we're going to plan now, whether we're doing an aesthetic case or whether we're doing a functional case or whatever, when we're making change, what is our first decision we need to make? And this goes without exception. And I don't know of any other things I would say that go without exception. But that first thing we need to determine is the vertical dimension of occlusion. And we mentioned that a little bit earlier in Kathy's case. But what is it then? This is one of the hardest things it took for me to really master was vertical dimension of occlusion. How to decide what that should be. And what it really comes down to is really a lack of understanding of what does this vertical dimension really impact upon. And there are really three primary elements it affects. First of all, certainly we understand that it affects the inner arch space vertically for our restorations. We understand that. But secondly, something maybe we don't think about is it also affects the anterior-posterior relationship of our upper and lower anterior teeth. And that's that envelope of function, or we call our available envelope of function. So we need to understand that vertical dimension has both a vertical component and an anterior component to it. In fact, in our system, we actually refer to it as the vertical anterior-posterior dimension of occlusion. And then finally, it impacts upon the invasiveness of treatment. In most cases, if we have an increased vertical dimension, as we demonstrated in Kathy, that's going to result in less invasive treatment. However, if you were to really increase, like certain methods suggest that all bites should be open, if you're going to open and you're going to end up doing restorative treatment that otherwise is not necessary, it becomes more invasive. But generally, an increased vertical dimension is going to result in a less invasive type of treatment. Now, so what is our goal? Our goal is to choose a vertical dimension of occlusion that results in the most conservative treatment that is also consistent with the patient's functional, ideal function, and if they have restorative needs, they're restorative wants and needs as well as their aesthetics. So that is our goal with our choosing our vertical dimension. So here we see, this is Larry's educated guess. So we are now at an educated guess at Larry's vertical dimension of occlusion. And how do I do that? Well, I'm based this on a series of photographs, a photographic series, and just honestly some experience. And I'm looking at this and says, do I believe that I can, with this vertical dimension, both the vertical and anterior-posterior relationship here, do I think that I can establish ideal aesthetics and ideal function? And with that being said, I want to jump back a little bit again here to that whole idea of function. And what do we mean by function? As we're talking about it today, there are really two components to that. First of all, we have phonetics, and I think we all understand phonetics. I'm not going to say a whole lot more about it. But the second element, which we've all talked about a little bit, is the idea of occlusion. And so in our system, when we consider the occlusion, as I already mentioned a little bit earlier with Kathy, we're not looking at that in a static manner. What we are really concerned with is understanding whether or not the teeth, interactions. Understand that when our teeth are interacting in a chewing cycle, in our functional cycle, okay, is that relationship between the upper and lower teeth in harmony with the most physiologic muscle activity in the joints? That's the functional occlusion. And we spent a whole lot more time going over that. But understand, it's interactive and it considers the muscles and the joints. Okay, so with that being said, I don't always do this. In fact, I rarely do this anymore, but I think especially beginners, this is a great place to start. And this is, again, after we did our reductive reshaping at that vertical dimension, I myself am going to go in and I'm going to work on the anterior teeth. And I'm going to see, well, can I develop really good aesthetic proportions, and can we develop really nice excursive function? And so we look at that, and if we look at our going into left working, we see this idea of a nice, smooth, progressive, lateral, excursive movement. In other words, when those canines come in end to end and they're ready to go into crossover, the lateral incisors and then the central incisors pick up. So when you're taking that side to side, it's just smooth as can be. And I can assure you that the muscles and joints love that relationship. But in any event, here we see right working here. And again, normally I don't do this step because I'm done enough, but beginners I think is a really good idea to do this. But anyway, so where would we normally go next? Well, what we're going to do now is we're now going to do a full arch wax up on this verified and validated mounted cast. And so what this represents then our educated guess at the aesthetics and the function at our educated guess vertical dimension of occlusion. And that's where we start. So, but now what do I want to do? Well, I want to advance those elements to being tentatively confirmed. And how do we do that? We do that with the functional aesthetic preview. All kinds of terms for this. Trial smiles, functional previews, whatever. But basically what we're doing is we're taking that design and transferring the additive elements of that design, which is typically all that there is, or mostly what there is, to that patient's mouth. And when we do that, we're going to want to advance in the vertical dimension of occlusion, aesthetics, and the phonetics, not at this point in time yet the functional occlusion, to being tentatively confirmed. And so once the patient likes the way it looks, once they like it, and it's not like the first time you do it, it's going to be right. Okay? In Larry's case, for example, it took us, I think, two revisions to get it to where we really, really liked it. That's when we are to the point then of being tentatively confirmed, again, on that vertical dimension, on the aesthetic design, and on the phonetics. Now, and here we see again Larry. If we see him in his full face, we see him before, and basically this is where things are tentatively confirmed. Now, an important element to point out here. Number one, do we always only do previews on verified and validated mounted casts? No. Okay, what is the purpose I'm trying to illustrate here? I am trying to illustrate my purpose in this case is to advance those elements, the vertical dimension of occlusion, and the aesthetic design, and also the phonetics, to being tentatively confirmed. Now, if I want to do that, yes, that does need to be on verified and validated mounted casts. Again, considering that with the problem profile patients we're talking about doing, okay? Now, but do I ever do one without doing them? Yes. Sometimes a patient comes in, they're having problems, and it's a nice aesthetic case and they have some functional problems. They're not sure if they want to commit. And maybe you want to market this or to kind of sell the case. Do we do, or could you do a preview on unmounted casts? Yes. But understand, if you've not gone through the process of verification and validation, you are at best an educated guess. There's nothing wrong with it as long as you understand what it truly, truly represents. So now what do we want to do? Now I want to advance both the vertical dimension of occlusion to being definitively confirmed, and I also want to advance the functional occlusion to being tentatively confirmed. And how do we do that? We do that as a result of redatablation with our data appliance. Okay, and so what have we done here? In this case, I have I've reductively reshaped Larry's posterior teeth to the vertical dimension that we did our preview on. Okay, I did the reductive reshaping, and then I did additive reshaping, in his case, just to the canines, centrals, and other canines. And that established our vertical dimension of occlusion. In other words, once Larry was comfortable with this, I can then say, once he's lived with this, it only needs to be a week or two, once he's comfortable with this, now our vertical dimension is definitively confirmed, and also our functional occlusion, that very, very important element, is now tentatively confirmed. Now, I need to make a couple points about this. First of all, this process should be a simple, quick, and inexpensive process. I had a method we had developed, I'd worked on years ago, where we'd go in and put in full contour restorations, composites, and things. It's not necessary, okay? And another point I need to make here is that in Larry's case, as we did in Kathy's case, her redatablation was a result of some reductive and some additive reshaping. But there are also cases where, we're going to get away from Larry for just a moment here, there are other cases where that process is going to be completely additive. So here we see a completely additive redatablation, and that was done with composite on the occlusal surfaces, nothing fancy there. That whole process took less than an hour to do. And realistically, well, what's done with the data appliance, we adjust the data appliance stop to the vertical dimension that we've confirmed is appropriate for our definitive final restorations, and I put the composite on there. Very easy process. Another example here, another individual, which is more typical, where there's not nearly as much wear. I'm just putting little, what I call functional occlusal stops only. And people will look at that and say, well, that can't work. Patient can't chew meat with that. This patient, actually, we've done 4/5 of his mouth at this point in time, and we did the redatablation, the additive reshaping, about 3 years ago. In the previous case, he was actually in that state because he went through some orthodontics. He was actually on that stable biomechanical foundation with those composites, doing well for approximately 3 years also. But anyway, so this is not something that, you look at this and say, a patient can't get by with that. They can, and they do. And so here we see then the stable biomechanical foundation in this case, with just a little addition, so little stops. And again, here we see why did we choose this vertical dimension? Because again, we had confirmed in the preview phase with his aesthetic preview, we confirmed this was the vertical dimension. This is where we could make it work, okay? And again, so why didn't we add on in this case? Why didn't I add on to the centrals and laterals? Because in this case, we literally moved forward with the restorative treatment, the anterior segment immediately. If this was a case where we were going to be deferring his restorative treatment for maybe a year or so, yeah, I would have added stops onto those anterior teeth. But the point here, and we'll get back to Larry here, is at this point in time then, we do our full contour wax up. And our full contour design, again, is done on that stable biomechanical foundation that we've already created, all right? And so at this point in time, we're ready. Now I want to get out my handpiece. Now I'm going to get out my handpiece. And so if you think about where we are at now, actually, before I do that, let's take a look here at the comparison between Larry's educated guess and his tentatively and definitively confirmed results. And we can see here is there are modest, but there are some very important differences between there, okay? So there's some important differences there. So now, again, so let's move on then with Larry's restorative treatment. And let's get to the preparation date. And what we see here, first of all, at this point in time now, understand, we are either definitively or tentatively confirmed on every important element we need to know. And now we're going to bring out the handpiece to do our tooth preparation. And what we see here in this slide is the stent of our wax-up design, and you get a sense of how much reduction we had there. And it looks like a lot. These were lucite reinforced restorations, very translucent, but they need to be thick. Plus, also he had a lot of stain underneath there. But that's not the important point here. If we look at here, now we're looking at the end of my preparation day. I'm checking my provisional restorations, and I'll get back to in a moment here why I'm showing that photo here. My question to you is, at this point in time, when I have spent the better part of a day preparing this patient's mouth for these restorations, is this a good time to figure out everything we have figured out already? Is this a good time to figure out the vertical dimension, the aesthetics, the functional occlusion? Okay, I can tell you that I've been in many, many cases where, it's towards the end of the day, I'm exhausted, the patient's tired, they're exhausted, they're either still completely numb or they're partly numb and partly hurting. This is not a good time to figure these elements out. And almost without exception, these patients need to come back for multiple appointments. And again, what happens to your efficiency? And again, the reason why I'm showing this photograph here is that I can't tell you how many times that when I finally got those provisional restorations refined, guess what? I didn't do enough tooth preparation, or in many cases, I did too much tooth preparation. That's the point I'm wanting to make here. So let's look at Larry's actual result here, and let's see how this came out with Larry with the process we showed here. And what we're looking at here, these are Larry's upper provisional restorations, and they are made from that stent that we made of his wax up that was done in the stable biomechanical foundation. And this is his result with 0 adjustment, no adjustment. And one thing that you'll note in that little red arrow there, remember, I didn't mention this to you. I should have mentioned earlier. Funny thing here, you see how we didn't prepare the second molars? Larry really is a neat guy. And he said, Karl, he said, I don't want to do my second molars. I want to leave them alone. Because he had lost, I think, number 2. And he said, Karl, I don't want to do it. I said, Larry, I'll do them for free. He says, no, I don't want to leave them alone. And the neat thing is, like 12 years later, they haven't changed a bit. But the point here is that getting to our vertical dimension and this whole idea of planning and the predictable planning is that when his natural teeth, he still had numbers 15 and 18 in contact. And note that with 0 adjustment, we are still at that exact same vertical dimension that we had planned everything out. Now, does it always result that I don't ever touch my provisional restorations? No. I mean, because understand that our aesthetics and our function at this point are tentatively confirmed. Now, it's rare, to be honest, it's rare that I'll make any aesthetic changes, but it's not uncommon to make little, remember little between tentatively and definitively confirmed? It's not uncommon to make little adjustments in the functional occlusion itself. In Larry's case, there was no adjustment, but in some cases, many cases, there'll be a little bit of adjustment, but little adjustment. Okay, so with that, let's move on and look at his lower arch. Again, we see here there were no adjustments necessary at all. And if you're looking at the soft tissue on the gingiva, on those lower anteriors, again, this is getting away from our case, but our concept or our system here, but a trick or a method taught to me by Frank Spear, which I think is great, is that when we're doing aesthetic crown lengthening, we do the soft tissue phase of that actually at the day of tooth preparation. And we do not advance or do not do the osseous phase of it until the patient absolutely is confirmed that's what we want it to look like. That's the final gingival contours we want to have. And it's a really neat system. That way, because typically you go in and you establish that crown lengthening first, but what happens after you've done your osseous phase and you want to make it a little longer or shorter? Well, anyways, don't want to go too much into that, but that's why those soft tissues are that way. And then here we see the upper anterior provisional restorations after the soft tissues have healed. And then as we showed you before, here's Larry's final anterior restorations, where they, I think, look really nice. And here again, now we see Larry with his tentatively confirmed preview and his final result. And no surprise, as we've tried to emphasize here, his projected outcome almost identically matches his actual outcome. So in concluding here, in Larry's case, I'd like to ask you, just think again about what we said. If you'd chosen a different method of treating, number one, would your projections have matched your outcomes as closely? And what would your actual outcome have been? Okay, and finally, what would have been, the experience, the stress, the efficiency, the relationship between you and your patient? And what can I say? And again, one more thing I would like to say, though, before we move on here, is what was there about Larry's case? What was there about Larry's case that said, I really need to go through this process, everything we've shown you here. What was there about it? And people don't know. It was the fact that he was our problem profile number 2. I had no idea. And there are cases, you could have cases where we could have maybe treated the case with look similar to this and done it in maximum intercuspation. And maybe you got lucky, and maybe he wasn't off like this. But that's an educated guess. What I'm trying to do, I hope this comes clear, is again, do you want to guess or no? I want to know. And that's what this system assures us of, okay? So with that, finally, in summary, if we look at our system, our physiologically guided treatment system for restorative success, there are 5 steps to it. The first three of which are to advance our key elements to being tentatively or definitively confirmed. And they are, first of all, verified and validated mounted casts. And again, I emphasize, if you don't do this, at best, your planning is an uneducated guess. Secondly, we do the functional aesthetic preview. Third, we create a stable biomechanical foundation at the appropriate vertical dimension for our restorative treatment. Then then we go in and prep our teeth, okay? And at this point in time, we're doing our tooth preparation again with our key elements either definitively or tentatively confirmed. And then finally, something we didn't even talk about, which is communicate this design with our laboratory. So with that, let's move on and talk just very briefly about the two tools we mentioned, but we didn't go into detail at all about, okay? And the first one, we went a little more into detail about the verified and validated mounted cast, but how about the data appliance? As we mentioned earlier, the first role of the data appliance is in diagnosis. And so what is the information the data appliance gives us? Well, first of all, it locates and records that ideal condylar position we described earlier. Secondly, something we didn't go into, it identifies the type and severity of parafunctional activity, also certainly very important. Also, something we didn't go into a lot of detail about is identifies that condylar condition. What is the orthopedic status of those joints? Fourth, we did talk about this, is can we establish a cause and effect relationship between patient pain symptoms and what we're doing, and the functional occlusion and parafunctional activity. And then finally, can you make this patient happy? How difficult are they going to be to treat, and are their expectations reasonable or achievable? So then the data appliance gets on and moves on to the second part of it, which is assist in treatment. And that is, if treatment is indicated, that is the data appliance's second role. And the objective of that is to create a stable biomechanical foundation. Now, that stable biomechanical foundation, again, then represents the union of function, biomechanics, and aesthetic and restorative wants and needs. So let's talk about that, and let's talk about, first of all, what are the requirements? What are the requirements of a stable biomechanical foundation? Well, first of all, as far as their functional concerns, we need to have interocclusal relationships that are in harmony with the muscles and the joints. Secondly, we need to have maximum intercuspation occur with equal intensity, simultaneous contact of all the teeth when the condyles and the muscles are in their most physiologic position. And then third, we need to have an anterior guidance that is in harmony with this thing we call the envelope of function. In other words, we need to have an anterior guidance that is protective of the posterior teeth, but one that is also protective of the anterior teeth. And that was one of the hardest things, one of the longest things it took me to really master and understand. That's a very important part of the process. So then where do we get into the restorative and aesthetic aspect of it? Well, it comes from a realization in the beginning here that I can meet these functional, these biomechanical requirements over a range of vertical dimensions of occlusion. And yet, if I choose a vertical dimension of occlusion to create the stable biomechanical foundation as a result of both additive and reductive reshaping, if I establish that stable biomechanical foundation of occlusion, if I establish that at a vertical dimension of occlusion that's consistent with the patient's outcome and allows us to most conservatively treat that patient, whether it's purely a functional case as it was with Kathy, or it was a restorative case as it was with Larry. That is our goal and objective of a stable biomechanical foundation. And again, it's important to understand that is the concurrent utilization of the data appliance with redadabration that allows us to create these requirements of a stable biomechanical foundation. And as we've also suggested here too, we've already given two reasons for why we create a stable biomechanical foundation prior to doing our preparation visit. Okay, first of all, it was to advance the functional occlusion to being tentatively confirmed. Secondly, it was to definitively confirm our vertical dimension of occlusion. But there are some others also. So let's take a look at them. First of all, as in Larry's case, you develop a stable biomechanical foundation on a patient that has pain, and all of a sudden they believe you, they trust you, and that case now becomes not just a TMD case, but as in Larry's case, it becomes a restorative case because their values have changed. Secondly, and hopefully we made this clear in Larry's case, I hope this came about okay, is it dramatically reduces the drama, the time necessary for the treatment phase of our patient experience. And the best way I think to illustrate this is if I were to compare the timetable here of how I used to do things. I used to spend maybe this much time doing the evaluation and planning, and I'd spend this much time in the treatment. Now, I spend, a little more time planning and evaluating, but I spend dramatically less time treating. I hope that comes clear. I hope I made that clear in Larry's case. And then finally, and something we didn't even talk about, maybe suggested, but didn't really go, the fact that if we establish a stable biomechanical foundation at this final vertical dimension of occlusion that is consistent with what there are all kinds of phasing options that are available. In other words, you don't have to treat it all at one time. And sometimes there are so many reasons why you may want to phase, and so many different ways you can phase. It may be because, like me, I'm getting old. I don't want to spend a whole day grinding down teeth. It's like, I want to break this up a little bit. Or maybe the patient's health or the patient's age, but also it may be for financial reasons. I mean, a lot of patients don't have maybe $40,000, $50,000, $60,000 to plop down to do it all at one time. Do it in phases, we can do that. So that's basically it. So what I'd like to do now, I'd like to spend just a couple minutes here going over the actual program, the Full Mouth Mastery Program. And I don't know how many of you grew up like me in the 60s with the space program. I love the space program. It was so neat. And I really like comparisons anyways, analogies, I guess is what I want to say here. So I see this really neat analogy between the space program and our program here, the Full Mouth Mastery Program, in three very clear ways. First of all, they both had very well-defined goals. They both involve or require sequential learning. And third, they both result in spin-off benefits. So if we look at each of those, well, what were the well-defined goals? The space mission, put a man on the moon and hopefully bring him back alive back before the 1960s ended. That was a very clearly defined goal. Ours is to safely, predictably, profitably provide ideal full mouth restorative treatment. Then as far as the sequential learning requirements, it took 20 manned space missions from the US before they put a man on the moon with Apollo 11. And why was that? Because each of those missions had a specific learning objective, technological, skills, and you couldn't do one step before you learn another step. Or maybe you might want to compare it even to kind of like mathematics. You know, we have to learn how to add and subtract before we can multiply and divide before we can do algebra. Well, similarly, with our system, we have 5 levels, and that's why that system takes a full year. Our program is a full year. And I'm not going to go into the program very much, but guess what the very first level is about? Verifying and validating mounted cast. How do we do that? Because that's really where it all begins, with the data appliance, okay? Then finally here, the third, spin-off benefits. So much of our technology today, even including the cameras that we're using to do this, have benefited from either the space program in the 1960s or even subsequently. Well, what are our spin-off benefits? First of all, treating TMD, TMJ issues, or occlusal disease treatment. And you may say, well, I don't really care to do that. Well, the reason you don't want to care to do that is because you don't know how to do it. When you learn how to do it and you're comfortable doing it, and you get the rewards of helping patients, giving them their lives back, it's wonderful. And then finally, next, we become a physician of the patient's entire masticatory system. This is what Peter Dawson would always say. So we're not just responsible for our patient's teeth and gums, gingiva. We're also responsible for their muscles of mastication and also their joints. And finally, maybe most importantly, it changes you, your practice, and the lives of those you treat in very meaningful ways. So with that, I'd like to leave you just a few final thoughts here before we wrap it up here. First of all, if you're not interested in doing this type of dentistry, I can certainly understand that. This program's not for you. Secondly, if you're doing this type of dentistry, and if your outcomes are matching your projections as accurately as ours are, if your methods are as efficient and as profitable as ours are, and if your control and flexibility give you really excellent treatment acceptance, you probably also don't need this program. On the other hand, if you are doing this type of treatment and you're not having the outcomes that we've demonstrated today, or if you're someone that just wants to starting to get into this type of treatment, I cannot encourage you strongly enough how helpful I think this program would be for you. So, but I need to say something here, and that is that our program, however, like any great endeavor, certainly involves sacrifice and commitment of time, energy, and money. I've really tried to demonstrate to you what I truly believe are the benefits you and your patients would realize as a result of taking this program. Now, John and Tim, whose names are up here, would very importantly, and I hope you reach out to them, they can discuss with you the details of the program, the upcoming schedules, the logistics, and the commitments that are necessary. And ultimately, in the end, only you can decide if it's really, really worth it. Jokingly, Tim and I once got together and we talked about this program and said, we're kind of like the Marines. What are the few, the proud, the Marines? Well, only 8% of the whole military force are active Marines. That's a very small part. Well, we're kind of like that. They're looking for a few good soldiers. Well, we're looking for a few good dentists. And I truly hope that some of you will join us, and I look forward and hope to see some of you in the future. And thank you so much for your attention.